Hi, this is Elliot Fishman, and welcome to our latest podcast. Make that Facebook Live. And we actually had Facebook Live yesterday. If you get time, you can go back and watch it. We had Reed Jobs from Emerson Collective here speaking about healthcare, and he gave a terrific talk last night at our symposium. So it's worthwhile listening to, which is probably from about 1 o'clock yesterday being Tuesday. So and I'm sorry I didn't do 12 o'clock today because I just had this conference call and I saw the most amazing things of what you can do with imaging. But if I tell you what I saw or the company I saw it with, I'd have to kill you. So I can't tell you anything. Anyway, so let's go back to something more practical. Pancreatic masses. So, we're doing a lot of deep learning here on pancreatic cancer. And we're actually really getting good results. And one of the things, of course, when we look at deep learning, one of the reasons we are doing it is we're trying to minimize error, right? And we talk about a 20 to 30% miss rate. And so we're trying to make that miss rate 0%, or maybe we can't be zero, but at least we can kind of get it down to the single digits. So that's really the goal. So then if you ask me, what are the pitfalls in pancreatic masses? What are the things that are missed? And okay, AI, we're going to teach AI to figure out some of these things, but what about the short term? What are we doing? So you realize you think a lot about things when you're doing AI, because what you're trying to do is teach the computer to think about things the way you think about things. And to teach the computer to say, let's look for a mass, the pancreas looks like this, and if it changes shape, there's a mass present. That's somewhat helpful. We do look at that, but recognizing that if you're only looking for masses, you're going to miss a lot of the small lesions which don't distort the outline of the gland, and you may miss things that are hanging off the gland, both head, uncinate, and tail. The second thing is we can look at texture. So we know that with contrast, be it arterial or venous, but especially venous, there's a certain appearance of the gland in terms of enhancement. There's a certain texture, and in normal patients, the texture will be variable, but it tends to be the same from uncinate, head, body, tail, all around the spectrum. If there are texture changes, then you have to be suspicious there's something abnormal. So one of the things we learned with cinematic rendering, it's a really good way of thinking about texture, that by changing the lighting model and changing the shadowing, you can change the texture. And you can accentuate normal texture, but more importantly, perhaps accentuate abnormal texture. So we've been doing a good job really looking at that. And I'm looking at that in my daily practice also when I do cinematic rendering, but also when I read the CT scans, and I'm trying to pay attention to that. Now, a thing that kind of fits in that category is when we're trying to train the computer, we talk about the pancreatic duct being dilated. Well, it's interesting, the computer people will say, well, I didn't train the pancreatic duct in the normal cases. And remember, we train the computer. But of course, you can't train on the pancreatic duct and the normal side, because most patients, you don't see a pancreatic duct if it's normal. And if it's normal, sometimes you see a little line, but it's, you can't even measure it. So it was a challenge because the duct is there. We know it's there. We just don't see it. So the question is, what do you do about it? So when you start looking at abnormals, however, then it's much better, because now we're seeing routinely the dilated duct. Okay, so that's cool. And then we've always said that one of the most common errors, and maybe the most common error I see in practice, excuse me for yawning, surely from outside films, is that if you see the pancreatic duct dilated and it changes caliber, or it stops, there has to be a mass present. Now, it's true, you can sometimes see a duct and you don't see a mass there, and theoretically it could be a stricture, it could be related to old trauma, but that's extremely infrequent. My rule is if I see a dilated duct and it stops, there's a mass there. And Dr. Karen would operate on those patients. Some people might do EUS, but it's not going to be normal. A duct cutoff anywhere is abnormal. And sometimes you don't see a mass, but remember, people talk about isoattenuating pancreatic cancers. I don't think it's 5%. People say 5 to 7% of cancers are isoattenuating. I don't think so, but I have seen many cases where only when I see the duct cut off Do I recognize the mass present? And sometimes is the most subtle thing. And sometimes, to be honest, I don't see a mass. I don't see a textural change. We've done some cinematic rendering that'll accentuate the textural change, but sometimes I just see the duct. When I have a 7, 8, 9 millimeter duct or more, and I see a transition and a stop, to me, that's pancreatic cancer. So that's one of the things where it's very easy to miss. The next thing I sometimes see in terms of masses, in terms of why people miss things, will surely be poor protocols. If you don't inject contrast fast enough, you can very easily miss things. We like dual phase, and again, in terms of lesion detection, venous phase is best, but arterial phase is usually pretty good. Arterial phase is best for looking at vascular mapping, which is like for pre-surgical planning. Venous phase with adenocarcinoma is best for liver metastasis, best for portal vein, SMV, splenic vein. So you need both phases, but that venous phase particularly is good for picking up smaller lesions. So those are the common things that I think are missed. I also notice where I see lesions missed. So, you look at the pancreas and it looks okay, but what you didn't notice was there's a lesion off the uncinate process. It's small, but it's there. And sometimes you see it encasing the SMA. You really didn't notice a mass in the uncinate. You notice the SMA is encased. It must be a tumor somewhere. You can't find a tumor, and you look very carefully, and you see an uncinate mass. And sometimes you see small masses poorly identified off the tail of the pancreas. And that's another thing that can happen. Again, your eyes are drawn to the normal gland, and you kind of lose it. And you don't notice that small little transition. So the ones I've seen even the computer have problems with, and surely we have problems with, are very small lesions off the uncinate or off the tail of the pancreas. So you want to be careful, surely in terms of training computers to read the scans, but in terms of training radiologists, humans to read the scans, you need to be very, very careful in that regard, or you can easily miss things in those locations. Now, if I said, what are the reasons people call a pancreatic mass if there's none present? Well, one thing you can say is autoimmune pancreatitis. Gland is swollen, sometimes the duct is dilated, common duct, pancreatic duct. Patient symptoms, weight loss, jaundice, sounds just like pancreatic cancer. Can be somewhat tricky, but remember, autoimmune pancreatitis usually isn't focal. There's not a dilated pancreatic duct. The gland is very large. Things are very bulky. It's treated with steroids, 40 milligrams times 2 weeks to cure the patient. Again, autoimmune pancreatitis is one of the things, if you don't think about it, patient CA19-9 can be elevated. Surely the ducts are dilated. You don't think about it, you'll miss the diagnosis. A very, very important diagnosis to be aware of. We see a reasonable amount of autoimmune pancreatitis, and usually they're not known. Many of them are coming in for surgery because it's felt to be a pancreatic mass. Remember, one thing is true for sure is that pancreatic cancer and autoimmune pancreatitis, particularly focally, can look very much the same. I think autoimmune pancreatitis is particularly hard when it's focal, as opposed to diffuse the entire gland. You also want to look at adjacent organs. Autoimmune pancreatitis will commonly involve the kidneys, so that tends to be a very helpful thing as well to me. So that's one thing. The other thing is, think of the scenario where you see a giant mass in the pancreas, and you notice 7 centimeters, 8 centimeters, nothing very tricky. But you notice there's no common duct dilatation, no pancreatic duct dilatation. In those scenarios, I can almost always say it's not going to be a pancreatic cancer. Now, what it can be, what gives you a large mass in the duodenum? Well, the most common thing would probably, think about, what are you thinking of? You're thinking about primary tumors, like say neuroendocrine tumor, but that's going to be vascular. You say adenocarcinoma, but it's not going to be that. One thing it could be, I'll go from the less common, is metastasis. Occasionally we see mets from something like breast or kidney going to the duodenum. That's a possibility. At times we see other tumors. So the classic tumor that occurs in that location are gastrointestinal stromal tumors. They're large, exophytic. Patients aren't obstructed, but they're large masses. They're commonly mistaken for the liver, not really recognized for what they are. The thing about just tumors now, Gleevec and then follow-up chemotherapy can usually do very, very well. So if I see a mass, now remember, 70% of GIST tumors are in the stomach, about 25% of small bowel, so it's not infrequent. But if I see a big mass in the duodenum, and I mean 7 to 8 centimeters, and I don't see duct dilatation and I don't see anything else, I'm thinking about GIST tumor. It's a good thing and a very important diagnosis to be able to make. You also can see other things. If I see a very vascular lesion by the head of the pancreas, obviously I'm thinking about a neuroendocrine tumor, but quite frankly, it's not always going to be a neuroendocrine tumor, right? If your patient has a missing kidney, you better think about a metastatic renal cell carcinoma. So there are certain things that tend to be positive findings, but you may not be positive. Let me always turn off your phone before you dictate or give a lecture. So that's another thing. The other thing that I think commonly people, including ourselves, make mistakes is sometimes nodes in the region of the pancreas can be confusing. Now, a good rule is when you have nodes, portal cable space, peripancreatic, usually the nodes are related to right colon cancer or maybe cholangiocarcinoma. Particularly colon cancer is very, very common in particularly the right colon cancers. And so you can get very large, bulky nodes in the peripancreatic space, the periaortic space, and can look just like a tumor. Often they don't obstruct ducts. That can be helpful, but sometimes they do obstruct ducts, usually the common ducts. So that's a really important differential diagnosis because I've seen it mainly with patients with right colon cancers, recurrence in the portal cable space, but you can also see things like lymphoma go there, but then you typically have larger nodes everywhere. You can think about melanoma, which can go almost anywhere. You can think about hepatoma or liver metastasis or something in the liver spreading to the local node. So those would be considered the local node. So that tends to be a very, very helpful thing. Now, another thing is, usually when you speak about carcinoma of the pancreas, you're talking about adenocarcinoma, which indeed is true. But as long as I'm talking about pitfalls, let me mention neuroendocrine tumors. Neuroendocrine tumors are typically vascular, both the primary lesion in the liver, the primary lesion in the pancreas, and metastasis in the liver. Now, we like to say that these neuroendocrine tumors are very vascular. That's the critical thing. And sometimes if you only do venous phase, you will not see the vascularity, and you may not even see the lesion because these lesions become isodense very quickly. Most of them I still kind of see, but I think the visualization is typically going to be best in the arterial phase. So it's very important when you're looking at pancreas dual phase imaging because neuroendocrine tumors behave differently, they're treated differently. Neuroendocrine tumors also give liver mets that are hypervascular that can become isodense very quickly. So again, when we're looking at pancreas, dual phase helps you avoid the problem of missing a lesion or misinterpreting a lesion. Now the other thing is, what if I have a vascular pancreatic mass? Obviously, it could be neuroendocrine tumor we just mentioned, but perhaps it's metastatic renal cell. Renal cell commonly is the #1 tumor that goes to the pancreas. Usually it's a decade or more after the patient was treated. So it's kind of, even the patient forgets that they had that renal cell. So when I'm looking at a scan, if I see a vascular mass in the pancreas and they're missing the right kidney, I know it's metastatic. Okay, that's just the way it is. So something really good to think about. So I do think about that. One of the reasons we do dual phases, so we have the arterial phase. So we're never going to be not recognizing those neuroendocrine tumors. So that becomes very important. What else can I tell you? I should go back again and make the point that to do really good pancreas, you need dual phase imaging, you need arterial phase, you need venous phase. We don't need delayed phase imaging. You want to inject at a good rate. We like to inject 5 cc's a second. You surely want to be above 4 cc's. And then you need to do post-processing. So I think it's those things all together that really make things excellent. Okay, I got a few seconds left. Let me look at questions. Someone asks, GIST or hypervascular, right? It's very interesting. We've published on this, but the small GIST tumors, those under 2 centimeters, can be very vascular. But once they get larger, which is not uncommon, over 5 centimeters or something like 20, Once they're larger, GIST tumors typically are hypovascular. It's also interesting that when you talk about GIST tumors of the small bowel, they can be the source of bleeding and intussusception, but particularly bleeding. But when I see a bleeding GIST tumor, it's 2 centimeters or less. When I see a GIST tumor that's 10 cm, whether it's jejunum or ileum or duodenum, that's not the situation. So the hypervascularity is the classic appearance of certain tumors like carcinoids, but the truth is GIST tumors are not going to be that way. Occasionally will occur, but that's not what we're thinking about hypovascular in most cases. Any other questions from anybody? And it was getting late. What time is it? It's 20 after 2. Time for lunch for some people. So let's stop there. I thank everybody for their attention. And we'll come back next week and we'll start all over again. See you then. Okay, and live video.